Welcome to PharmaDocs with your host, myself, Dr. J. Reznick, and Dr. John Roberson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice. Well, hello there, John.
Jay, good evening. How are we doing?
Good. What's going on back home?
Man, just busy at work, taking care of patients, treating patients, loving what I do, living the dream, man, just like you.
Yeah. Some days. I don't know about every day. Some days I just want to go home and make a cocktail.
That's right. But man, we have a great profession, don't we?
Yeah, we sure do.
And I tell you, I love coming on doing this. I enjoy it. And I enjoy the feedback we get from our fellow colleagues.
Yeah.
They appreciating us taking out our time to educate or present what's going on out there in pharmacology, because you've got to stay up to date in pharmacology.
Yeah.
There's just so much going on out there. And I mean,
there are new drugs every month, and we've got 6 to talk about today.
Yeah. And I mean, and those new drugs are going to be patients you're going to see every single day in your office. And you know, the higher the drug use, the higher the risk for a medical or some type of sedation emergency in your office if you do sedation.
I had a patient came in, I think it was on 20 different medications. 3 or 4, I had no idea. I didn't know the drug, so I had to look them up. Yeah, but that's how many new drugs are out there. I think we said on our very first webinar that if there's what do we say, like 80 new drugs a year, and you've been out for 10 years, that's 800 drugs that you may not even know exist.
Correct.
Yeah. Unless you watch TV.
But you're going to be held responsible if you inject local anesthetic or give some type of pre-op med or post-op medication, and they have some form of adverse drug reaction, and you weren't aware of it. That falls on you. Yeah. Okay.
It does.
And that's something we all need to know, understand, and realize.
For sure. Well, should we get started with
let's do it.
Today's stuff?
Yes.
Okay.
Yes.
All right. So we want to start off by just thanking one of our new sponsors, iCore Connect. You may or may not know of them, but they are in the space of getting you set up to do electronic prescriptions. And so it's basically all cloud-based. You can access it from anywhere. You can prescribe from your phone. It's all HIPAA compliant, and all the drug information is all up to date.
And it's always backed up too, Jay.
Yeah. So you can look up your patient's drug histories, see what you prescribe, see what other people have prescribed if they have the same system, and also get alerts when you're prescribing a drug. And patients on other things, because it's in your EMR, it'll tell you about conflicts between drugs they may be taking, whether the patient, prescribing something the patient may be allergic to, or something about, food cautions you got to check out, dosage warnings, and it also connects you directly to the Lexicomp database.
Yes.
So
just a great program to have. I mean, because again, I just mentioned this before you said about iCore RX. When you prescribe that medication, you're responsible for what it does to that patient, because they're going to be on a plethora of medications. So here's another checks and balance for you before you prescribe something that could be harmful to a patient.
Yeah. So if you haven't gone e-prescription yet, or you don't like the system that you're using, check out iCore and iCore RX. I think you'll be happy. It's a great system, great product. And in fact, it's been endorsed by, look at all these TDA perks, the California Dental Association, Nebraska Dental Association, Oklahoma,
Mississippi. There it is.
Oh, there you go.
Yes. Yeah. How you like that?
Yep. All right. So they're legit. So the first drug we're going to talk about is nothing new, but it's a new form of a drug that has been out since 1998. Was called, or it's still called, Maxalt rizatriptan, and this is a new form of it in a basically a dissolvable film, kind of like those Listerine little things. Yeah. It's a serotonin antagonist, and it's used for the treatment of migraine, acute treatment of migraine. So it's not used for prevention. It is used to treat acute attacks. Right. And it's indicated for anyone who's over 12 years old and weighs at least 40 kilograms or more. So that's about 90 pounds or so. Bless you. So migraines are a type of headache that's characterized by recurrent attacks of severe throbbing, pain, nausea. Usually the headache is on one side, light sensitivity, and aura. And if the aura causes basically a blind spot, it's known as, and because the way that I get these, so I know what they look like, you get like a little like scintillating lights. They get bigger and bigger. The ring gets bigger and bigger, and your blind spot gets bigger. And these are called scintillating scotomas. Scotoma means a blind spot, and scintillating means they're kind of flashing, like neon. And so this is a good drug. This is what I take. I take Maxalt, and it seems to the headache pretty quickly as long as I take it quickly. So this Rizafilm is going to be even more convenient to take. You don't have to have water around. You just dissolve it on the tongue, and then swallow it. But the way this drug works is, as you may or not know, migraine is caused by vasodilation in basically on the vessels in and around the brain. And what happens is the trigeminal nerve will release something called CGRP, calcitonin gene receptor protein, or receptor peptide. And what that does is it causes vasoconstriction. And even spasmodic vasoconstriction. And that's what causes the migraine. Yep. And what this drug does is it binds to those serotonin receptors and inhibits that inflammation. So it inhibits that vasodilation and inhibits the inflammation also. So it brings the headache to a close. And you want to dissolve it on your tongue for about 2 minutes, and then swallow what's left. And if after 2 hours it's not really doing what you want it to do, the headache's not better, you can take a second dose 2 hours later. In fact, you can take 3 of them within a 24-hour period. So this is a drug you're going to see. You may know what Maxalt is, but now you've got Rizafilm. If patient puts that down on their medical history, you know what this is for. The drug has a number of side effects. Most common in adults are kind of malaise, lack of energy, feeling kind of sleepy. I sometimes get like a tightness in the back of my neck, or pain or pressure in your chest or throat, maybe dizziness, maybe nausea. And a lot of these side effects are due to the vasoconstriction or opposing vasodilation. And so it can even cause myocardial infarctions, myocardial ischemia, angina, arrhythmias, but it can also cause cerebral hemorrhage and subarachnoid hemorrhage, and stroke, and GI events too, GI ischemic events. So it's a fairly safe drug, but some people will have some rare side effects. But I mentioned the ones that are most common, and
Jay, the thing about it, when you said one about chest pain, that's specifically Prinzmetal's angina.
Yeah.
And, for all of our colleagues out there, anybody with Prinzmetal's angina, that is someone you do not want to treat in your office, because they're having chest pain not only during any form of exercise, or
they may just be laying there doing nothing, or they may be sleeping.
They're having chest pain at rest as well. This is not a candidate to be treated in your office. Okay. So when you're going through your health history and you're asking, okay, tell me more about your chest pain. All right. Do not treat this person. Let them first see their cardiologist.
How often do you get your chest pain? What brings it on? What do you take? Usually it's nitroglycerin tablets or spray. Does the first tablet eliminate, get rid of your angina? How quickly does that happen? Do you have to take a second? Do you have to take more? So every positive response to something on the medical history should be answered with another question to delve deeper into what's going on, so you know exactly how severe this patient's disease is.
Right. And see, Jay, right there with you saying that, because you were saying they could be on nitroglycerin or nitroglycerin spray or the tablet. The other thing is they could be on a continual dose of nitroglycerin disguised by something maybe called by isosorbide.
Yeah.
And so you got to know your medication there. Like, okay, they're on something isosorbide. Well, that's another form of nitroglycerin. They're taking that on a regular basis.
Yeah.
And on top, taking the occasional 0.4 milligram tablet. Okay. So, this is a person you don't treat in your office.
Yeah. And one of the things that this medication can lead to, especially if the patient's on other medications, is serotonin syndrome, which we've talked about before.
We have.
And basically, a lot of different types of drugs, drugs for depression, seizures, migraines, pain medications, vomiting, Parkinson's disease, including propranolol, ergot drugs, which are used for migraines, as well as other triptans can cause this. SSRIs are another
herbal
example.
Drugs.
Yeah, herbal drugs, and not only SSRIs, but SNRIs. So those are, and monoamine oxidase inhibitors. Those are 3 different types of antidepressants that all work by raising the serotonin level. And even St. John's wort. And then, of course, also on that list is cocaine and ecstasy, which hopefully you don't have anybody who's on those when they come in the office. But this is something, the serotonin syndrome can happen fairly rapidly within a few hours, or sometimes it takes longer. And the symptoms that are related to it are restlessness, agitation, confusion, sometimes hallucinations, tachycardia, sweating, shivering, diarrhea, dilated pupils, high blood pressure. Most commonly are asthenia, which is basically asthenia and fatigue. And asthenia is where you just physically can't get up and move. Somnolence, pain and pressure sensations, dizziness, and nausea are the most common signs and symptoms that are seen, especially in early serotonin syndrome.
So, I mean, Jay, for example, like what you just said, before you listed all those symptoms, you made the comment, like, if you prescribe something, then they'll see these symptoms later on. So I couldn't help but think you do some type of invasive procedure at 1 o'clock in your office. And I don't really want to write something heavy, so I write tramadol. That's right. And they're on SSRI or MOA inhibitor. And then later on that evening, you get a phone call from the loved one or escort of that patient, and they start listing these out. Now, what's your differential diagnosis? That's what you got to start thinking.
Yeah, because tramadol also works by increasing dopamine level.
Correct.
And this is, when the patient calls you, tell them to go straight to the ER or even call 911. And what they do in the ER to treat this, a lot of benzodiazepines, cyprohexidine, which blocks the serotonin production, sometimes IV fluids, and medications that will stop the syndrome. And if it's life-threatening, they may even paralyze the patient and intubate them just to get them stable until the serotonin level drops.
So that's called a medically induced coma.
Exactly.
When they do that.
Yep. All right. Our next drug is
Omisirge.
Yeah. Let's hear about that, John.
Isn't that a pretty cool name? And Omisirge right there. And it's a nicotinamide modified allogeneic hematopoietic progenitor cell therapy. That was a mouthful.
Yeah, what the heck is that?
Wow.
Yeah.
Oh.
Yeah. And so it's used in patients that have some type of hematological malignancy to reduce the risk of infection following a stem cell transplant.
And again, I mean, how many times have you have heard this, Jay? You've talked to a patient, or of someone, a close friend or something. They have cancer, and then they got their chemotherapy, then they wound up with an infection as well too.
Yeah.
Well, or they got stem cell transplantation and it didn't take because of an infection. All right.
Yeah.
Now we have Omisirge.
Yeah.
Okay.
So basically, what they do is before the patient gets the stem cell transplant, and it frequently comes from umbilical cord blood,
Correct.
because that's got all the stem cells in it. They basically knock out the bone marrow either with radiation or chemotherapy, which puts the patient at very high risk of developing infections. And then they do the bone marrow transplant. And so this drug is used to when their white cell count is almost zero, before they start. They get the new bone marrow transplant and start producing their own cells. Extremely high risk of infection. And so one of the things that this drug does is it helps the neutrophils recover faster,
much quicker.
Yeah, and reduce the risk of bacterial and fungal infections. And this is given by an IV infusion. And so what this is, the nicotinamide modified allogeneic hematopoietic progenitor cell, is basically cord blood that has been processed with NAM to enhance the number and the functionality of the targeted cells. And it's given in two parts. There's actually the first dose is called the cultured fraction, which is what I just described. And then the non-cultured fraction is administered after that. And that is the rest of the umbilical cord transplant.
And, Jay, the patients also receive a pre-medication before any Omisirge is given at all. Mm-hmm. And that's an antihistamine, hydrocortisone, and acetaminophen about 30 to 60 minutes before as well, too.
Yeah, exactly. Because there's a real high incidence of transfusion reactions and graft versus host disease, failure of the graft. It can also cause the bone marrow transplant itself can actually stimulate other malignancies and even rare genetic diseases. But the infusion reactions and graft versus host are the most common. But again, as John said, those are they're given medications beforehand to reduce the risk of that happening.
And, of course, with the neutrophil, always remember when you treat these kind of patients as well, to find out what their ANC is before you treat them. Actually, absolute neutrophil count.
Yeah. And you also want to get probably a CBC, have their physician do a CBC and make sure that they are in a position healthy enough to have treatment.
And as Jay just said, when you talk to their physician or your assistant may talk to the nurse, get that in writing and how you're going to treat that patient with them, and document.
Yeah. Have them email you or fax a copy of the CBC with the physician's initials or signature on it. That's what I would go for. All right. Next drug is Qalsody or tofersen injection. And this is a drug for ALS. I think we talked about an ALS drug called Radicava.
That's right.
Was it earlier this year or last year? I can't remember.
It was early this year.
Okay. Yeah. And so this is, again, a new drug. And what Radicava did was it was a free scavenger, free radical scavenger. So it reduced the effects of oxidative stress and slowed the progression of ALS. And what this drug does is it's for a specific type of ALS. It's for patients who have a superoxide dismutase 1 gene mutation. And so those are the patients that this drug targets, and it's actually it's relatively new. It was just approved April 25th.
Yes.
So not too long ago.
No.
And it's on an accelerated approval. And I think we talked about what that means last month rather. And so it's been approved because it causes a reduction in plasma neurofilament light chains, which has been seen in patients that have this type of ALS. And so what it does is it basically slows the progression by basically being an antagonist to the receptor for this mutated SOD1 gene to slow the progression. The SOD1 gene And it's given a little differently than other drugs we've talked about and we'll talk about today. And this one is given intrathecally. So intrathecally, if you're not familiar with what that means directly into the cerebrospinal fluid of the spinal cord. So it goes through the dura.
That's every 14 days, Jay.
Yeah, every 14 days at first for 3 times, and then ongoing every 28 days as needed thereafter. So that's different from an epidural injection, which goes on the outside of the dura, hence the name epidural. And the kind of things we can see, common reactions with this drug are pain, fatigue, arthralgia, CSF leaks, white cell increase in the CSF, muscle aches, and on rare occasion, elevated intracranial pressure or aseptic meningitis. So, when you're doing an intrathecal injection, it's not, benign, but it's quite safe from almost every patient, with rare exception. They just have some minor side effects. But for patients who suffer from ALS, it's another tool in the toolbox to try to slow the disease. I don't think there aren't any drugs that have been approved yet that will stop the progression of ALS, but we have 2 new drugs this year that will slow the progression.
And again, on that accelerated approval pathway as well, because they saw the benefit there, and they knew they had to go ahead and get this drug out. Yeah. Just like we got one next month, for this month, for the next, I saw where one for RSV is coming out as well too. It's just been approved. So again, I mean, look at what happened to the amoxicillin market due to RSV.
Yeah.
All right.
Yep. So just the accelerated drug approval, what that means is they released it early before the big studies, like the type 3 studies, which are the big trials, type 3 trial, because they saw this benefit. However, they're still going to do these type 2 and type 3 drug trials. And if they find that it actually does have benefit, then they'll continue to approve it. But if they find in these big studies that it doesn't, then they will probably not approve it for use after that.
Right.
All right. So let's move on to our next drug, which is Vowst.
Vowst.
Yes.
And now guess what? We've already got another drug out like that as well too, Jay, that we talked about last year.
And actually we talked about in January, Rebiota.
Rebiota.
Yeah. And this is, so it's a little different. Rebiota was basically from fecal donors. And so it's basically a mix of normal, healthy microorganisms. But this drug Vowst is in the form of fetal microbiota spores. And the advantage of using spores is they're more resistant to breakdown and by the GI tract, and also they're resistant to, they're just more resistant to breakdown. So they more of them make it into the GI tract when it's given. It's given oral. It's an oral
medication. That's right.
Oral medication.
That's right. And we talked about how bad C. diff is as well too, Jay. I mean, it's a potentially life-threatening. Again, it's another one of those situations where we prescribe an antibiotic, and it's more than just clindamycin. Everybody, I mean, there's
any antibiotic can cause it.
Yes, and you get that phone call. Hey, I've been having diarrhea for several days, but it's bloody now. And you need to take that to heart. You need to be very serious about where you want to send that patient to.
Yeah, because what you've done with the
gastroenterologist.
Yeah, or even to the ER, because they'll probably need to be admitted to the hospital. So what I'm sure you know is that the antibiotic, whatever you give them, will throw off the normal microbiota in the gut, and allow it'll kill certain organisms, but which will allow the Clostridium to proliferate, and that's what causes all the symptoms. And so this Vowst again is a basically a consortium of highly purified Firmicutes spores, which the name of that phylum was changed to Bacillota, and it contains live bacteria from human fecal matter, and part of that mix are Lactobacillus, Bacillus, Clostridium, but Clostridium genera, Enterococcus, and Ruminococcus. So what it does is it modulates the disrupted microbiome and tries to get it back to a normal state where the C. difficile are not running amok. And so this is used not for treating C. diff diarrhea, C. diff infection. It's used after at least 3 or 4 days after they've been treated, and usually it's treated with antibiotics like vancomycin, which kills everything. Which is why they call it Vancoterrible, is what
they used to call it in medical school. Yeah, but yeah, the other thing too, though, Jay, if that patient comes in on that medical history and they say, "Hey, I have a prior history of C. diff," when you talk to their GI doctors, there's a good chance they're going to put them on Vowst before you treat them, because he or she's going to ask you, "Are you going to need to put them on antibiotics?"
Yeah, right, because they're at high risk of this happening again.
Absolutely high risk, and so. Right there, you've got a good relationship with their doctor, and then y'all are managing that patient's case together.
Yeah.
And then, of course, like I've said before, we're going to document that in the chart. Hey, I spoke to the patient's GI doctor.
Yeah.
We're going to start Vowst before I do the procedure. And then I do plan on prescribing antibiotics. The patient's been made aware of what to look for to call me or their GI doctor.
Yeah. And it's taken 3 times a day.
Right.
Like I said, after the infection is cleared, at least 2 to 4 days after their last infection was cleared. So in addition to antibiotic use, patients with weakened immune systems can get C. diff overgrowth, or patients in the hospital, it could be transmitted from patient to patient on surfaces, or you can reactivate.
Wash your hands.
Yeah, you can reactivate a past CDI infection.
Yes.
And so this this is something we need to take seriously. I've seen it a couple times, in the last 5 years with patients, especially my older patients, is they are at increased risk of C. diff C. diff infection in their GI tract developing. So you want to be aware of that.
So Jay, which one would you want if you had C. diff, Vowst or Rebiota?
Whichever one smelled the least bad.
I'm gonna have to go with Vowst.
Yeah. Right? Okay. All right. So because of the spores.
Because of the spores. That's correct. Because
I'd want to be treated with antibiotics first, and then probably then the Vowst. All right. So
just remember Vancoterrible. Okay. Yeah. Just remember that. Okay. Yeah.
And the other was Amphoterrible. That was the other one.
And Amphoterrible.
Yeah. All right. So the next drug is another drug that has been around for a long time. Abilify has been around in pill form since 2002. And this is a new form of it called Abilify Asimtufii, which is, I don't know where they come up with these names. But this is, Abilify, which is Riprazole, is it's an antipsychotic for schizophrenia and bipolar disorder. It's a partial agonist at dopamine D2 receptors and serotonin 1 receptors, 1A, and an antagonist of the dopamine 2A receptors. And so, like I said,
so Jay, if we gave tramadol, what can happen? We've already talked about it, right?
Yeah. Yep.
It's called
serotonin syndrome. Right? Exactly. So, they released Abilify pills in 2002.
Yes.
And, when you're treating a patient with bipolar disease or schizophrenia, what is the biggest downfall?
I'd have to say when you're treating that, it's probably non-compliance with your medication.
Exactly. To get patients who have bipolar disease or schizophrenia to take their medication on a daily basis is a tall task, because they don't like the way that they feel on it. It slows them down. They don't feel like themselves, but they need it to prevent the psychotic episodes. And so over the years, they developed other forms of it, like an intramuscular injection that's given every couple of weeks, another one that's given every month. And this one's interesting. In 2017,
a little bit longer here.
In 2017, this one lasts for 2 months. Abilify Mysite. Okay, and what that was a tablet that was formulated with a Proteus sensor, which is a little tiny circuit board or IR board that's about the size of a grain of sand that's actually attached. It's embedded in the capsule. And the patient would have a wearable sensor, and it would tell their doctors how compliant they were with taking their meds.
Wow.
Unfortunately, in 3 years later, Proteus filed Chapter 7 because it couldn't find a good market, and it couldn't raise funding to keep going. But it's an interesting concept.
Yeah.
To put a tracker on drugs to see how compliant the patients are. But this intramuscular injection given every 2 months is a good way to go. However, you want to, before physicians are going to start a patient on this injection that lasts 2 months, they're going to put them on daily dosing first to make sure the patient has no adverse reactions to it. So that they
I like these injections, Jay, that have like a depot in the body for at least 1 or 2 months right there.
Yeah.
It also reminds me of like whenever we did our training in the ER, if we had a patient that had a really significant infection, we didn't think they might not return back to us or not go get their antibiotics, bicillin. That drug was sitting in the fatty tissue for a good 7 days. What a great drug.
Yeah. Yeah, you don't hear about it too much anymore.
No, but it served well.
Yeah.
All right. But you did not want to inject it fast.
Yeah.
All right.
And the common adverse reactions to Abilify include increased weight, acathasia, I can't talk today, which is basically an inability to stay still, injection point pain, and also sedation, which is
what you already said earlier.
Why the compliance rate is so low to it. Let's see. I got to try that again.
Acathasia.
Acathasia. There you go. All right.
We have so much to talk about, Jay.
Should have done a shot of espresso before we came on. And our last drug is another
Uzedy.
Schizophrenia drug, Uzedy.
Uzedy.
Or Risperidone. And you've probably heard of Risperidone before because that was introduced in 1993 as the drug Risperdal. So it's been around a long time. And this is, again, a long-acting medication that's given intramuscularly in order to maintain the patient's compliance instead of a daily pill. It's given once every 1 to 2 months. And, just like with the last drug, with Abilify, some of the uncommon side effects are things like increased dementia psychosis, neuroleptic malignant syndrome, tardive dyskinesia, metabolic changes, hyperprolactinemia, orthostatic hypotension and syncope, leukopenia, neutropenia, granulocytosis, cognitive and motor impairment, seizures. And so this drug also has those, but the more common things are basically the sedation, dizziness, akathisia, anxiety, abdominal pain, nausea, vomiting, all those things. And again, site reactions. So those are
Jay, the other thing too, this drug has had multiple names over the years.
Yeah.
Persersis. Okay.
Yeah. Yeah. That was a
sub-Q once month.
Yeah.
And then earlier this year, we've already talked about Rycondo. Okay.
Yeah.
And that's a intramuscular injection every 2 weeks as well, too.
And that was introduced this year.
Yes.
Earlier this year. Yeah.
Earlier this year.
Yeah. All right.
So you're starting to see more and more of these long-term medications, just like we see with the bisphosphonates, either Prolia or Reclass.
Yeah.
One is 6 months, the other is 12 months. You're going to continue to see this more and more with medications.
Mm-hmm. Yeah, absolutely. If they can be given a form of the drug that lasts for months, again, you're going to have much better compliance no matter what it's for, but especially for the psychiatric disorders.
Yeah, but I do like what you said earlier. First try them on the trial using the pill or by mouth formulation to make sure there are no significant side effects. And then if that is fine with the patient, they tolerate it well, then move them into the injection phase.
Long-lasting injection.
Treatment.
Exactly.
That's right.
Exactly. All right. So we are moving right along. We're now on the medical emergency of the month. And John, what are we talking about? What's our emergency?
Gosh, Jay, I'm wanting our users out there to think about, this is something we use every day.
Every day. Wow.
Every day in our office. Okay. So what medication could there is a potential for an overdose. All right. If you don't pay attention to how much you administer, you probably already know what the answer is right now. It just doesn't work orally, but it also works systemically as well too. And Jay, the package insert for this medication is very important to all of us because it is a true medical legal binding document.
Because a plaintiff's attorney will ask for discovery. They'll ask to see this and blow it up, on a 10 by 30 screen for all the jurors to see. So what is this mystery drug?
It's local anesthesia. Okay, so we're going to talk about the local anesthetic overdose. And I just want to mention what Jay just said right there, because we're going to show you the package insert, because I know many a time in my lectures when I bring this up, Dennis will say, I had no idea this even existed.
Yeah.
Okay.
Fact, well, let me show it right.
You're not taught it in dental school, Jay. I mean,
well, you're taught how many carpules you can give. Was basically within, so that's kind of a number you remember.
That's right.
But every patient's going to be affected differently based on their weight, their metabolism, other medications they may be taking. And so they can have mild symptoms, moderate or severe. A lot of times they'll show anxiety, slurred speech, confusion, tremors, headaches, dizziness, a metallic taste in their mouth, drowsiness, blurred vision. And I actually, in an oral surgery meeting I went to a couple of weeks ago, we were reviewing some mortality cases, and there was a case of a healthy 16-year-old who had a cardiac arrest under general anesthesia. Why? She was given 10 carpules of lidocaine with epinephrine.
Wow.
And that caused a cardiac arrest in a healthy 16-year-old. Yeah. So
was it in office or at the hospital?
It was in office. And of course the team didn't recognize what was going on and delayed care because they, healthy 16-year-old shouldn't have cardiac arrest. But eventually, the paramedics came and she was gone about 15 minutes later, because you've got 6 minutes to save the patient basically. And
at the tops, okay, so no defibrillator was brought in, no ACLS medications administered.
I don't think so. But the big thing they didn't do is they didn't start CPR. They didn't start BLS.
That was my next thing. Was
that's
BLS
one of the things you see all the time is clinicians panic, and they don't even assess their
airway,
ABCs,
breathing, circulation. That's right.
And they never start CPR because they're panicking.
And when did this happen? Just recently?
I think it was a couple years ago, because it's a closed case.
Oh, it's a closed case.
Yeah.
Right.
So,
and that's usually when we find out is like 1 or 2 or 3 years later after. Like if you need to find out about it.
Yeah,
Okay.
exactly. And so like for lidocaine, I think the max is 7 carpules if you're
Yeah.
using, and for septicaine or articaine, I think it's 6. But you want to check that out. Just make
And
sure you know that number so that you
well,
don't give
the
a patient
weight
a
base
local
is,
anesthetic overdose. Yeah, it's
yeah.
based on for kids' weights. For adults, it's basically kind of
All right.
standard. Yeah. So obviously, the way you're going to manage this is you're going to stop giving him any more local anesthetics, get the patient supine, get oxygen on them, and monitor their vital signs. Call 911 as one of the first things you're going to do. And if the symptoms are severe, if they're mild, you may just observe the patient for an hour. But if they're having severe symptoms,
yeah.
Call 911 right away.
And don't let that patient drive home if they're by themselves and some of those symptoms just occurred.
Yeah.
Go ahead and have an escort pick them up as
Yeah.
well too.
Yeah, exactly.
And Jay, going back to not initiating BLS again, that's one of those things we talked about in our other little live webinar we did called "A Patient Dies in Your Office. What Happens Next?"
Yeah.
That's one of the part of the 8 deadly failures that occurs in dental offices, because if you panic because you can't believe this is happening, and then we're taught to be able to do BLS, but we forget how to use it, how to do it.
Yeah, I think that's at the top of the list.
Absolutely, it's the top, and we'll see that in just a minute when we get to our algorithm here in a second.
So here is our algorithm, and you'll notice at the top, number 1 is remain calm.
Try to. You're the team leader, dentist. Okay. Everybody's looking at you. Okay.
Yeah. So as we mentioned, you're going to stop administering the local anesthetic. You're going to place the patient supine, monitor their vital signs, give them oxygen, and then watch them for about an hour. If they don't get better or if they get worse, then you're going to call 911 right away. And put the patient, instead of being supine, upright in a more comfortable position. They may have seizures, so you can make sure you're always protecting them from injury. And you should have a medical emergency plan for your office that you would initiate at this point for local anesthetic toxicity and for seizures. And you're going to continue monitoring them and keeping them safe until the paramedics get there.
Now, Jay, let me jump in. So when you're going down the checklist, I mean, this has happened. This is going on very quickly. This is rapidly taking place in your office. But if you haven't prepared, if you haven't gotten with your staff, this will not take place well at all. Okay. This will be chaos. Okay.
Yeah. You have to go through all these emergencies with your staff.
Yes.
Way in advance of any emergency that actually occurs, and repeat it on a regular basis. So like every month have a new emergency.
And the thing about it is this, okay, when Jay just said call 911, I want everybody out there listening to me. Well, never feel embarrassed about calling 911. Never, ever. No EMS paramedic or will ever come to your office and embarrass you for calling them. That's their job. That's what your tax dollars pay for. Okay. And when you do recognize there is a code blue or a medical emergency or somebody's dying in your office and you say call 911, you need to forget about that because you trained a person in your office to call 911. The last thing you want to do is, after about 8 or 9 minutes into this medical emergency, where is 911? Because it will be the longest 8 or 9 minutes of your life. Okay. And then you have a staff member, well, I didn't call.
Yeah, you got to have someone who's assigned. That's their job, and they know
that's their job. They know it, and they're going to carry it out no matter what.
Yeah. And sometimes the paramedics come to your office, and the patient's fine by the time they get there.
And great.
And they just kind of verify that they're fine, and they leave.
That's right. And they'll more than likely they'll say, now, do you want us to take you to the hospital to be checked out? No, I'm fine. You just sign some documents and you move on. Okay.
Exactly. That's how it works.
All right. So Jay, keep going down the algorithm. So I interrupted you just a little bit. You're going through basic life support because all of this is going on quickly.
Yeah. And if they have seizures, what you want to do, if you're trained to start IVs and give IV sedation, is to give them some diazepam or midazolam. either IV, or you can give midazolam IM if you can't start an IV.
Correct.
Diazepam really burns when you give it IM. It burns when you give it IV too. So, midazolam is kind of the preferred drug, and hopefully that'll at least stop the seizures from occurring.
And if you do that, remember now you're in airway support mode also as well, because now you've sedated the patient to help counteract their seizures going on.
Yeah.
And make sure you are monitoring those vital signs the whole time, and somebody's writing all this down. Okay.
Yeah. Yeah. Vital signs. And if you have a pulse oximeter, use it.
Absolutely.
Yeah. Absolutely. Yep. Most definitely. All right. So this is that package insert we were John was alluding to. I should have put it earlier in the deck here, but so basically, John, tell us what it says.
Well, it's on all the warnings of the many local anesthetics we have.
Yeah, it comes in the package. Yeah,
yeah. Articaine goes even further, Jay. I mean, they'll have the warnings. They also have a vasoconstrictor overdose as well too. But bottom line, they're telling you better monitor all these patients.
Yeah.
Okay. And it's a great idea to know the blood pressure on all patients before you give a local anesthetic.
And heart rate.
Let me just read this out. Dental practitioners who employ local anesthetic agents should be well versed in diagnosis and management of emergencies which may arise from their use. Resuscitative equipment, oxygen, and other resuscitative drugs should be available for immediate use.
Yeah.
They just put everything on us, Jay, right then. All right, 100%. Hey, use our product, but guess what? You better be prepared.
Yeah, use at your own risk.
That's right.
So the key thing is look at your patient, see how much they weigh. So if it's a patient in their 80s who weighs 90 pounds, you're going to use the per pound formula and try to give them, you should try to give all your patients as little local anesthetic as you need. For 4 wisdom teeth, I use 2 lidocaine and 2 articaine.
Yeah.
And that gives me great local anesthesia. And so, if I have to give more, I'm always conscious of how many of each that I've given so that we don't get to that danger zone.
That's right. And the other thing too is when you administer local anesthetic, don't throw away your carpules. Keep it on your surgical tray.
Yeah.
So that you're able to keep count of that as well too.
Yeah. Yeah. Exactly.
And never
or on a little trash bag that's attached to your tray.
Yeah.
Like a clear plastic trash bag.
And the other thing, I know so many of us are busy and all that, and there's some cases where you just do local anesthetic only. Never go into a room, inject local anesthetic, and then walk out and leave that patient alone.
Yeah. Make sure your assistant someone is with that patient all the time.
Absolutely.
Yeah.
Because there's cases out there where bad things happen when nobody was in the room.
Yeah.
All right.
Yep.
Jay, what did the death certificate say on that 16-year-old cardiac arrest due to local anesthetic overdose?
I think so.
Wow.
I think that's what it was. Yep. Totally preventable.
So what that means, everybody listening, when she got to the hospital, they drew toxicology levels and all that as well too. So they had all of that information.
Yeah. Actually, I don't think she even made it to the hospital.
Oh, she didn't?
Yeah.
So the coroner just automatically went ahead and just...
Yeah, they did tox screens. Yeah. And they found, overdose of local anesthetic as well as a ton of epinephrine.
Okay.
All right. Well, actually, they probably wouldn't see epinephrine because it dissipates so quickly. It breaks down quickly. Okay.
Yeah. It'd be the local.
Yeah. So we're just going to put in a shameless plug for one of the courses.
One of the greatest products ever created for pharmacology. That's what you're trying to say, right, Jay?
And it's on Dental Learning.
Yes, dentallearning.net.
And so we have, among our other courses, we have the DOMES, the Dental Office Medical Emergency Simulation course, which is 4 modules that goes through all the medical emergencies. And I've actually shown it to my office. and made them sit through. We do like a lunch once a week where they watch it. And the other thing we have is our pharmacology package, and so we have drug updates or drug monographs, I guess, in an interactive form on dentallearning.net, and goes over arrhythmia drugs, asthma drugs, and drugs for COPD, bisphosphonate drugs, cholesterol lowering drugs, congestive heart failure drugs, depression, anxiety drugs, diabetic drugs, adrenal and thyroid drugs. And we talk about drug-to-drug interactions. We talk about emergency drugs. We talk about medications for epilepsy and seizure, and for hypertension, opioids, and we also have modules that are the top 200 prescribed drugs, as well as I prescribe this, but the patient is on that, which basically
and we just have you covered. I mean, that's you don't have to go to a lecture. You've got everything right there, and you can access this 24/7, 365. All right,
as many times as you want.
As many times you want, and plus, we cover a lot of medically compromised states. In each one of these modules, we cover medical emergency preparedness. You're just getting a whole plethora of just great information for day-to-day practice use, bottom line. All right.
So check out dentallearning.net. And you'll see what we have available. We're in many categories: pharmacology, oral surgery,
anesthesia,
prescriptions, anesthesia,
sedation.
It's easy to find all of what we have available. All right. Well,
and Jay, I guess you got to put a plug in for dentallearning.net. I mean, they're awesome. There's
great
people. There's a lot of other authors out there with great courses on dentallearning.net as well.
Yeah.
And they just do a fine job in the presentation of these courses.
Yeah, they did an outstanding job putting this all together for us.
Yes.
The domes, as I mentioned, it has 4 different modules. It's $99, and you can buy that on dentallearning.net.
Great course there.
I've got a course, Responsible Opioid Prescribing for Dentistry. And what I did was I made it a 3-hour course that includes all of the requirements for all of the states in the U.S., including Hawaii and Alaska.
That took some time. Okay.
So
it
was a lot. It did. Yeah. And so it should be acceptable in most states. California, where I am, I had to do a specific one for California. I'm doing one for New Jersey, actually a live webinar, I think next Friday. And then I am doing one in Ohio, which is 2 hours and tailored just to them, live lecture in Cleveland, I think in the end of June, somewhere like that.
Awesome.
Somewhere around there.
Yeah.
And you can see about all those and register on dentallearning.net. Oh, we just mentioned this one too. That's also on dentallearning.net. And so our next episode of PharmaDocs is going to be heading your way on June 9th. And
new drugs, new medical emergencies, always.
Yep.
All right. It's all about keeping you updated.
Yeah.
All right. And we just can't thank you enough for watching our show. And thank you for the comments, and anything we can do to make it better, let us know, please. We're here for you.
Let us know, because actually we are here for you, and we are
absolutely
we are real live clinicians that that do
love what we do.
Yeah, we love what we do, and we do it every day.